So I'm Philipp Lurz, Director of Cardiology, University Mainz, and today we will talk about the subgroup analysis of the TRISCEND II trial. I think there's no doubt at that point in time that whenever there is the presence of TR severe or greater, that morbidity or mortality really increases in these patients. And at the beginning of transcatheter therapies to treat TR, we all expect that we also will see great differences in heart clinical endpoints in clinical trials. We didn't do so, and maybe one explanation is that in clinical reality we treat quite sick patients, but in the clinical trials we enrolled slightly healthier patients, and in healthier patients with lower risk it is more difficult in a smallish clinical trial to see significant differences. So in the TRISCEND II trial, the safety and effectiveness of the EVOQUE transcatheter tricuspid valve replacement system was assessed. Over 400 patients were enrolled. It was a 2-to-1 randomization, so 2 patients underwent TTVR, and then 1 patient was randomized into control. And the primary endpoint was a win ratio analysis of a hierarchical endpoints, including heart clinical endpoints, but also quality of life at 1 year. The key finding of the analysis of the primary endpoint of the TRISCEND II trial was that the study clearly met its primary endpoint with a win ratio of 2.02, which is a highly significant win with a very robust magnitude of effect. But this win was mainly driven by improvements in quality of life, but somehow surprisingly no difference in heart clinical endpoints such as mortality and heart failure hospitalization. So one of the goals of further analysis of the TRISCEND II trial was to see whether we can find specific patient populations in which TTVR actually results in benefits also with respect to heart clinical endpoints. This comes very much down to baseline risk. The higher the baseline risk, the more benefits patients derive from treating TR. And one way to assess baseline risk was to separate the cohorts into patients who started off with a baseline TR severity grade of severe, and the other group with massive and torrential. And this is what we have done in this subgroup analysis. And we see that these two groups, severe compared to massive or torrential baseline TR, that they behave quite differently. I think it's a very important signal now that we see superiority of TTVR with respect to heart failure hospitalizations in patients who started off with massive or torrential TR. So for me, it's a clear yes that we not only treat symptoms, but also make a difference in terms of heart clinical endpoints. In patients with severe TR, it's slightly more complex. I think that it needs to be guaranteed that it's really severe and not moderate or even less. So maybe one approach would be in borderline echo scans to repeat the echo scan and make sure that it's truly severe, because these patients clearly benefit from a symptomatic point of view, but I also believe that these patients during a longer follow-up will benefit in terms of heart clinical endpoints. The most important takeaway from this TRISCEND II subgroup analysis is that TTVR can reduce the rate of heart failure hospitalizations, particularly in those patients who start off with massive or torrential TR. Irrespective of baseline TR severity, there's a huge benefit with respect to quality of life and functional capacity. And the right patient population, balancing the risk of the procedure and the baseline risk in patients at an early stage of the disease with severe or even less than severe TR, is something which needs to be explored further in the future.